So thanks everybody for coming to this webinar today on the 15th of August. Um, Today's webinar is called Trans Rights Are Drug User Rights. This webinar is being hosted by Euro Input. So just to introduce myself, my name is Leo Jeffries. I'm a trans non-binary drug user activist. I'm originally a settler from the unceded territories of the Sailks and of the Squamish, Musqueam, Tsleil-Waututh people known as Vancouver, BC. I've been living in Ireland for the past 8 years, and my background is harm reduction and community activism, as well as a living experience of substance use. Currently, I work as an independent harm reduction and drug policy consultant, as well as director of operations for the European Network of People Who Use Drugs, also known as Euro Input. Euro Input is the regional drug user network fighting for the health and human rights of people who use drugs in Europe and its neighboring countries. We focus our work around connecting street level activism to regional policymaking spaces through thematic projects such as coordinated country campaigns, opiate agonist maintenance, treatment, literacy, and rights, examples of best practice in peer-led harm reduction, and advocacy interventions. So, for those who are just joining us now, we are recording this webinar. If you would like to keep your video off, that's perfectly fine. We're going to have three speakers today, and we're going to have questions and discussion at the end. So please feel free to introduce yourself in the chat, as well as put some questions as we go along in the chat as well, and we will feed back those to the speakers. So today we're discussing about how the rights of trans people and drug users intersect. And when we're talking about trans people, we mean anyone who doesn't align with the gender they were assigned at birth. And for drug users, we mean anyone who uses drugs. We're going to talk specifically about service inclusivity, specific needs around NSP, and interactions between HRT and other drugs, the pharmacokinetics of trans people. So without further ado, I will introduce our first speaker. So Lucille from Flirt, welcome. And would you like to introduce yourself, Lucille?
Yeah, I'm just doing my PowerPoint at the same time. So, okay, everything nice? Is the screen okay?
Yeah, we
Okay,
can
so
see it perfectly.
okay, so I'm a trans woman from France. I'm living in Paris currently, and I'm an active drug user, and I've been organizing around harm reduction for trans drug user and trans people who are doing self-medication for the past 5 years, I'd say. And so my talk will be about like inclusivity of services for trans people. My talk will be in three parts. The first part, I will present briefly the work I've been doing for the past years, which is linking trans organization with harm reduction organization. And then I will discuss how to make your services inclusive or welcoming for trans people. And then a little bit of like tips and tricks that you can put in your organization for trans people. So the initiative I've been working on for the past year is called the Trans and Talks Initiative, so Trans and Addict in English. So it's a mutual aid program for trans drug user in the Paris area. It was created because Flirt, the main organization I'm part of, is a mutual aid collective for trans women. And a lot of the people who were helping, following, or who were working at the organization were drug users and were facing specific struggles. And so we decided to have a dedicated program for this. The program is centered on three main actions. So there is a monthly gathering for trans drug users where we discuss practices, we do workshops on social rights, as well as like self-medication practices, or we also do writing sessions because we are planning to do a Zen this year. We also have health mediators, which help people get access to health, basically. So be it about drug use, but also like general health. And then we do the part which I will focus my talk on today, training for NSP and addiction centers. And so this part was created because a lot of the people that we were helping with the collective had struggled going to classical NSP center or addiction center because they were facing transphobia, or the services that were provided by the spaces were not adapted to their practices or to their daily struggle. And so this action started by a partnership with Gaia, which is the organization that's running the drug consumption room in Paris. And so the thing that we did is we started having a talk with them, and then we have regular talks like once every month. And a direct effect that we saw basically was that when we started discussing with Gaia, there was only one trans woman going to the drug consumption room, and now there are dozens basically. And that's because something that I will discuss a lot in this presentation is how partnership between harm reduction organization and trans organization allow for multiple redirection. What we call is that, for example, when we have somebody who's homeless and needs a place for injecting that stuff, we tell them to go to Gaia Paris room. And then when a trans person is coming to the drug consumption room, they give them our numbers or the next monthly gathering for them to come to our spaces. We also did multiple partnership with the NSP services, especially because we were looking for some syringe and needle that were not available usually in multiple NSPs. On the inclusivity in service provision part, I think one of the biggest points is that you as harm reductionists here already have all the tools to be able to welcome and be inclusive for trans people, basically. So non-judgment, respect of one journey and identity. This is really important because harm reduction in multiple countries was funded also by trans people, or trans people participated a lot in the early development of harm reduction as a philosophy and analytical practices. I put the reference of that book on the right. It's a book that has been out for like a year or so, I think, and it's really a nice read if you want to read it. I really encourage it. The second part is knowledge is necessary for inclusivity. You need to have basic knowledge of one population specific struggle and condition in your country and region if you want to be able to welcome them. That does not mean that you need to know everything or that you need to be a specialist of one issue to be able to welcome people. It's just having general knowledge basically will help you understand how people are affected by their environment. So, for example, how is it possible in your country to get access to hormones? Can you get it through a general practitioner, or do you need to go to a psychiatrist first? Where, how, what are the delays and everything? That's, for example, knowledge that's quite important. Uh, how is it possible to change your name and gender on official documents? What is the name of the nearest trans organization from you? Like, if you're in a big city, do you know the name of the nearest like trans organization or even LGBTI organization? And also, you should have like some knowledge about like a specific struggle that trans people faces in, I'd say, Europe, but so higher poverty rates, higher suicidal rates, higher frequency of sex work, especially for trans women, and high prevalence of medical violence. Trans people face a lot of medical violence, be it through what we call transphobia, so the non-respect of one identity, and also by the psychiatrization of our journey of our life. This makes trans people less likely to accept psychiatric evaluation, for example, or mandatory psychiatric follow-up. And this also have an effect is that a lot of trans people do not have medical follow-up in their day-to-day life. And so your role as NSP, if you have a medical practitioner, can be really important for trans drug users because you might encounter people that have no medical follow-up at all. And so if you can be that space, it's super nice. More specifically on the product, I'd say trans drug users are basically like most drug users is that they do drugs. So you can find cocaine, heroin, everything that you can find in the normal population, you will find in the trans population. But there are some specific products that you can find. I'd say you find more for trans people. So cathinone, 3-MMC, 4-MMC, uh, GBL, GHB, ketamine. Oh, I forgot to. So specifically ketamine in intramuscular injection. That's something that's in France. I don't know about the rest of Europe, but in France, it's highly prevalent in the trans population. Uh, and a lot of people, trans people who are taking hormones for their medical transition are doing what we call self-medication. Basically, that means that they are using hormones that they get on the black market. So be it pharmaceutical grade hormones that they get through smugglers or also non-pharmaceutical grade hormones. So hormones who are brewed by usually trans people and who are sold on the streets, for example. And this has an effect is that a lot of the trans people who are taking hormones are taking hormone by injection routes. This means that trans people are usually uh, have used syringe and needle outside of drug use, and so they also tend to use more syringe and needle for drug use, as they are accustomed to the material, basically. And this means especially for intramuscular, because usually hormones are taken in intramuscular route. You will probably meet some trans people who are taking, for example, heroin in intramuscular route. And this tends to be a problem with the NSP today, is that a lot of them do not provide intramuscular material. And that's uh, some kind of a struggle. And more for the, let's say, tips. So those are like general tips, and you are not like obliged to follow them, and they're also debatable. So it just if you have like no idea how to make your space more welcoming for trans drug user, those are like some kind of idea. So you can put like poster, brochure, booklets regarding trans people, trans healthcare, those kind of things. This makes your space more welcoming, basically. It means that you know that there will potentially be drug users in your services and also that you care about it. Then the second thing, so in France, for example, it's a bit different, but let's say I'm going to read this first. Ask to any person their preferred pronouns or wait for the person to gender themselves. So I underline the any person. If you start asking person their pronouns, ask everybody. Otherwise, you just feel like outed as a trans person because somebody kind of perceived you and don't know how to gender you, and so you feel bad basically. But it also depends on the language. For example, in French, everything is highly gendered, so you can just let people gender themselves. Uh, I've adapted syringe and needle for the use, so that was what I was talking to you about. I think there's the whole drug use part with intramuscular, but also there might be trans people that want to come to your needle and syringe exchange place because they need needle and syringe for their hormones treatment, basically. Because in a lot of countries, needle and syringe are not covered by Social Security. And so it's difficult for people to access them if they want to use it for drugs, but also if they want to use it for their hormonal treatment. If you have a GP, a doctor in your service, if he or she can prescribe a blood test for hormone monitoring, this is really important and really helpful because, as I told you, a lot of people are doing self-medication, so they have like no medical follow-up. And if they can prescribe hormones, it's super nice. This is highly dependent on your country legislation. For example, in France, any general practitioner can prescribe hormones. So general practitioners that works in an addiction center can also prescribe hormones. But in some countries, it's not possible. So this you need to get up to date to the legislation of your country. I know that TGEU has a map which kind of explain it, but also you should probably contact your local trans organization about this. If you can do testing for vials. So a lot of the black market hormones are delivered in vial form, so a multiple usage injectable product. And it's very hard to test them. So one organization is actually doing this, so Trans Harm Reduction, which we'll talk after me. But this would be super helpful if NHP exchange centers who do testing could do testing also for hormones. And usually in most countries where drug testing is available, the legislation allow you to also do testing for hormones. And then the last, which is I think the most important, get training from your local trans organization and develop joint action. And it can go both ways because you may be not knowledgeable about trans people, but some trans organizations are not knowledgeable at all about drug use. So you should do joint trainings and do it both way and then develop action together. For example, one of the actions that we developed in Paris was that there was a NSP that was doing a non-mixed day, basically, and they had struggled to get trans people there. And so we hosted a meeting there. And so a lot of trans people came there for the first time through our organization and then became like day-to-day people that were coming by, basically. So yeah, you should do network. That's the thing that we are doing a lot in Paris, bit with every harm reduction organization that we can. And I guess that's it for me. And maybe the other people want to add something, I guess.
Thanks so much, Lucille. Um, that was a great presentation and super informative. Um, I especially like a few points you made about for service adaptation, for general knowledge, services thinking they need to know everything before they do something, but really, you don't need to know everything. There's just basics you can do to make more inclusive spaces. Um, and the point you made about education and connection for trans people coming from trans people, rather than a service kind of assuming what they should kind of create, like actually connecting with the communities because it makes sense, not only ethically, but also like logistically, it's going to work better if you have the design coming from the trans community themselves. Um, so, Fiona or Amanita, I think we'll just keep questions and comments until the end, unless you wanted to respond to anything else. Okay, great. So, Fionn, you're up next. I'll let you introduce yourself. Fionn is from Trans Harm Reduction, and really happy to have them here with us today. Thanks, Fionn.
Thanks, Leo. I'll get my slides up on screen and then I'll keep talking. Um, oh, is it working? Does that look good to everybody?
Looks great.
Okay, so I was really pleased to hear in Lucille's presentation many of the things that I feel like talking about today as well. Um, and it was also great to hear us mentioned. I'm from Trans Harm Reduction. Trans Harm Reduction is a grassroots, volunteer-led organization across Ireland and Scotland. Founded in 2009. I'm from Ireland. I live in Scotland. That's why it's in both places. That is literally why it's those two countries. And I deliberately wanted to call it trans harm reduction. I wanted a connection with drug users and the drug using community. And so it was great to see Lucille say the principles of harm reduction are the same principles as including transgender people in your work and we having that non-judgmental, respecting each other's journey and respecting each other's identities is foundational to harm reduction. So I love to hear her say, if you're in this room, you already have the core skills to implement trans inclusive practice. So what trans harm reduction does is we do a lot of stuff. The foundation of it is we are self-medicating trans people and we're trying to keep each other safe. We're trying to do what we can, share information and create networks and structures of support for people. Uh, we test DIY suppliers, as Lucille mentioned. Uh, we've been doing this for years and it has a massive support base for it. And we're keen to share the way we do that. We're actually thinking about switching our lab that we're using, and if we do, it'll be much cheaper and it'll be much more able for other organizations to do that. But we're gonna do a test run with the new lab, and then we will absolutely love to connect with other organizations who would like to do that testing themselves. More people testing is better. But we've been running that for maybe 4 years. And we also operate peer support networks in both Dublin and Glasgow with a view to maybe like operating a few more. We have a lot of uptake in the Glasgow one and increasing uptake in the Dublin one. And we all know from the one-to-one peer support that we give people, if we wanted, we could have like four peer support groups every month. I've also got our needle exchange on here, where we copied a United States group called Trans Needles, which was a postal needle exchange operated through COVID. And we just copied that idea. We started running a postal needle exchange. We were like, here's the needles that you need here, and we can just post them to you for free. So I'll talk about that. This whole talk is me talking about what is the needles we need? What is the deal with transgender people and needle exchanges? So just a disclaimer, the total number of self-medicating people is not known or knowable really. So anything I'm saying, if it doesn't sound right to you, I'm just talking about our peer network knowledge, what we know from talking to hundreds of people. There might be different patterns in other areas or just even other people in the same cities I'm in. So why do we need needle provision? As Lucille said, the most common administration route for DIY hormones is injectable HRT. There's a number of reasons for this. Like Lucille said, when using, we would say gray market, the black market or gray market hormones, you're taking some risk into your hands. And if you're trying to reduce your risk, you may want to do estrogen monotherapy, which is where you do estrogen alone and enough estrogen so that that estrogen overcomes the testosterone in your body, and that would obviate the need for using hormone blockers. Because using hormone blockers come with a range of side effects, and to reduce the risk of side effects, you can get rid of the blockers altogether. So it is what, in general, when doing peer support work with people, we advise that estrogen monotherapy, if you are doing no medical follow-up, you have no medical supervision, it reduces your risks. So it is very popular, and so you need needles for that. For testosterone, self-medicating communities often rely on steroid communities who produce, test, and distribute injectable testosterone exclusively. In the past, there was testosterone gel available, but that dried up in the UK, at least in like 2020. People here say they would buy large money to get it from anywhere. It doesn't seem to be available from anywhere unless you were diverting a prescription. But primarily, everyone in our communities, estrogen or testosterone, is using injectable. So what is needed if you were injecting your hormones? How is this different from if you're injecting drugs into your veins or injecting intramuscularly or subcutaneously? Nevertheless, there's slightly different needles required. So if you're a self-medicating transgender person injecting your hormones, You're not going to be injecting more than 1 ml at a time. So you only need a 1 ml syringe, maybe even a smaller one if you can get your hands on a 0.5 ml syringe. We usually advise to use a drawing needle because, like Lucille said, people use a multi-use vial. So you'll have like a 10 ml vial, but that'll last you like 9 months of estrogen or 6 months of testosterone. So you use a drawing needle to reduce the risk that the top of that vial will give you any injection site trouble. We also use an alcohol pad on the top of the vial to reduce bacteria risk there. So you use a bigger drawing needle often. You don't have to, but it just is faster. And some people recommend using a blunt needle. There's a divided opinion on whether you should use a blunt needle and basically create a hole and keep reusing that hole, or using a sharp needle. There's a if you want to look more into this, it's about vial coring and the risk of the top of the vial like deteriorating a little bit and getting into the product. We tend to advise using a sharp drawing needle, and then you're going to need an administering needle, whether you're doing intramuscular or subcutaneous. They're slightly different needles. IV drug users have a different set of things required, and so this is what you usually find in injecting equipment provision sites. They will have 1 ml syringes, which is similar, but they often have a built-in needle, but their built-in needle will be 28 gauge as standard, at least in Scotland. And that is usually too small for trans self-medicating people. This is because our hormones are suspended in carrier oils, and those carrier oils are thicker than the water that drugs that are cooked may be suspended in. So we don't need cookers, we don't need filters, we don't need citric, we don't need a tourniquet. We just share the need for maybe an alcohol pad and a sharps container, but we have different needs. So like Lucille mentioned, it's an additional thing for needle service injection equipment provision centers to hold and to know what people might need and know what questions to ask. So this is the basics. If anyone is injecting anything, you need access to safer injecting information, you need reliable access of safe supplies, and you need harm reduction information in the case that you don't have access to safe supplies or you are in a compromised position. So we are aiming to fill this need. What do we as Trans Harm Reduction do? We provide safer injecting information both on our website and on our social media. We also go along to in-person events and I'm sorry if you can hear that banging, by the way. We go along to in-person events. We'd have little flyers. We also just have our peer support people at events. We talk about things. We like to demystify injecting as a thing, make it seem less scary. And again, always align ourselves with harm reduction communities in Glasgow, harm reduction communities in Dublin, and be present there and be like, there is also information about this needle use. We ran our postal needle exchange for since 2020, so 5 years now, and we have since partnered with Transgress the NGS, which is a Dublin-based organization, and they have more volunteers, they got more people, so they're doing our postal stuff so people can get their supplies quicker. We also operate a healthcare fund which supports any healthcare needs that people have. Sometimes people pay for private blood tests and can't cover the costs, and we would help them with that cost. We use it a lot to support people for bulk purchases of their own supplies. If they have stable housing, somewhere to stay, and they want to get 100 of each of the items of their injecting supply kit, we would be able to cover the cost of that. It's only about 25 quid. It's not very much. We have a relationship with universities across Ireland, and so student unions in Galway and the universities in Dublin and the universities in Cork and various other smaller universities have information, a link to us, and then actual needle supply kits for people and little sharps containers. In keeping with that sort of thing, we have collaboration with other community organizations in Dublin and in Glasgow. There's a bunch of grassroots transgender organizations and also national organizations. We have relationships with all of them. We would be present at Pride, anti-Pride events with pre-made injection kits. We have a relationship with an organization here who are trying to create community blood tests for people because we have large self-medicating communities. And if you know anything about the political environment in the United Kingdom, it's worsening for us here. So we're getting reduced access to GP monitoring and blood tests. So we have a community organization trying to run that ourselves. And we are not doing that. We're speaking with them. We would be sitting there with as people come in for their community blood tests, we would give them information about self-medicating more safely. Do we have any connection with established needle exchanges? The short answer is no. We would like to. We made some efforts to do so. We like back in 2020, we were really pushing for it. Then we were like, maybe it's COVID, maybe they're only saying no because they're strapped, things are weird. But as things opened back up, we tried again and we were again unsuccessful. I have a feeling from looking at the chat of this webinar that there's a bit of an appetite for maybe making that connection now, maybe having like a relationship with us, copying some of what they're doing in Paris. But to date, we haven't probably tried in a year and a half. We've been unsuccessful. We do have positive relationships with drug user advocacy networks and drug user organizations. We just don't have that kind of relationship that Lucille was describing of like we give them training, we have our meetings in their spaces, and we would like that. I was really inspired by listening to that talk to be like, I think we could do some of those things, but at present, we do this on our own, and we just know those people and hope that they know about us and invite us to things. So this is a question I'm leaving for the discussion after our presentations, and I think Lucille was answering some of them as well in hers, and I'm sure that Amanita will be too. But beyond provision alone, what would a needle exchange need to consider to serve us well? And it is like in the previous presentation that we are a multiply marginalized community. We are more likely to be impoverished. We are more likely to have higher risk lives just in general, and perhaps not have connection to stable housing, family, or support networks. But I think that this will be a discussion that we can have after all the presentations, and I'm looking forward to hearing what people say, and I'm looking forward to what Amanita says after me as well. So I will wrap up there. Hope I wasn't talking too quickly. If you want more information about our organization, we have an unreasonably good looking website. We have a really nice web designer. It looks way better. Like I'm telling you, we are 5 gay people with an Instagram account, but our website looks very slick. So thank you very much for all your time. I will stop sharing here.
Amazing, Fionn. Thank you so much. And I need the contact for your web designer for sure. And I just want to say for trans harm reduction, it actually was my 3-year T anniversary, testosterone anniversary a couple days ago. So 3 years, and that's like thanks to trans harm reduction, and their support. So really happy to be facilitating this conversation and having everyone here. Yeah, and I picked up on one thing you said about diversion, and it's funny because as drug users as well, that comes into the language sometimes, and the criminality around medications or like OAT, for example, being diverted. So it's interesting to think about the intersections of, diverting HRT, but really this idea of diversion is actually community support. So that's great. For people asking, we are going to share the slides of this afterwards we can email the participants. And without further ado, I would like to welcome Amanita, and I'm going to be sharing Amanita's slides. So give me a second to do that. You can introduce yourself.
Thank you so
Amanita.
much, Leo. Yeah, I'll start introducing myself. I also need to verify they have the latest version because I just made a few changes. And thank you, Alexi, for sharing the website of TGU. I will be sharing later both the website for the Trans Rights Index and Map and the Trans Health Map. Leo, I just want to verify that you have the last version of my presentation. Yes, that's the last version of the presentation, or it should be that one. Great. So, hello, everybody. My name is Dr. Amanita Calderon Cifuentes. I am a Colombian trans feminine person. I'm a two-spirit. I'm an indigenous woman from the Muisca tribe. I am also a sex worker and a drug user, and I have a PhD in molecular biomedicine, and I work for TGU as senior HIV research and advocacy officer, and I also serve as NGO delegate for Europe as one of the half of the NGO delegation for Europe at UNAIDS. And today I will be talking about the biomedical needs of transgender people that use drugs in relation to HIV specifically. I'm going to be talking a lot about drug and drug interactions. I'm going to try to include a little bit of policy and advocacy efforts that we're doing from TGU and from the delegation. And it's a lot of information, so please slow me down if I need to be slowed down. Also, I am a talker and I talk sometimes a little bit fast. So please just, remind me. So you can start the next slide, Leo. The next slide, it's going to come in parts. So the first, if you press 3 times, press 3 times, Leo. Yes, exactly. So one of the things that I wanted to talk about in this presentation is that the community of people that are neurodivergent and the community of trans people and the community of people that use drugs are in fact like these big syndemics, right? So like basically by syndemics, I mean these are communities that their medical needs, their global health needs live in a constant overlapping because we are quite often the three of them. There's a high prevalence of neurodivergency and a high prevalence of drug use among transgender people. And I will talk about that a little bit more later. But there is especially one thing that we are perceived to have in common, and that to some degree it's true we have in common, and that, Leo, if you press, is mental instability. And that mental instability understood as depression, anxiety, loneliness, and PTSD, which is mostly caused by, press one more time, 2 more times. Dopamine dysregulation, mostly. We will see that it's also caused by serotonin dysregulation, but this is not caused directly because we're trans or because we're drug users or because we're neurodivergent, but it's caused because, hit the arrow twice, we live in okay, 3 more times. Actually, 4 more times. Yeah, in a neurotypical system that is full of transphobia and systemativity and that highly criminalizes drug use, which makes our experiences way less fun than what they should be. 3 more times and then one last time. So all of this leads to this dopamine dysregulation, which causes high mental instability. And so what I will be trying to do in here is to provide you with as much information as possible so that dopamine dysregulation doesn't happen, which doesn't lead to mental instability. And then you can go ahead and be as trans and as druggy and as neurodivergent as you want to be. Hit again. Like next slide. So we have a really high prevalence of neurodivergent people among the trans communities, as I had mentioned before. We see that in a study published in Nature Communication in 2020, they found that about 15%, almost 15% of the trans communities showed symptoms of autism on or ADHD. And for this reason, the conclusion was that transgender people were 3 to 6 times more likely to be neurodivergent in comparison to cisgender people. These understood as cisgender people between the ages of 13 and 49 years old. Now, there's also a high prevalence of mental instability. There's 42% of prevalence of PTSD, and there's also 3.6 times more likely risk or chance for trans people to use drugs than cisgender people. 63.9% of prevalence experience loneliness and 70.7% of perceived self-isolation. These are really high numbers that are, as previously mentioned in some of the presentations. Oh, I don't know, where did you go, Leo? You can go back one. Yes, one more. No, I said back. Like, go back. Yes. Yeah, okay. Now you can go one forward. I'm sorry. Yeah, so basically, what I would like to start by explaining is how dopamine and serotonin work. So dopamine and serotonin are 2 neurotransmitters that we naturally produce in our brains that are in charge of 2 very important things. Dopamine is in charge of motivation, reward, and executive function. Serotonin is in charge of regulating your mood, decreasing anxiety, and giving you emotional stability. When you're taking hormonal replacement therapy, estrogen enhances dopamine synthesis, and for that reason, it improves the mood of people that are taking estrogens. For this reason, it's not highly recommended to reduce your estrogen levels in really high amounts. Second, Testosterone it modulates dopamine, and it often reducing depressive symptoms because it's a mood regulator. So for this reason, it's also really important for trans feminine people, especially, to not reduce their testosterone levels way too low. Now, how is this related to neurotransmitter dysregulation? When you don't have this dopamine and the serotonin levels in an let's call it normal, understood normal as the a normal distribution, like in the median of the normal distribution, mathematically speaking. So when you don't have this normal dopamine and serotonin levels, you can have really strong mood swings, you can be highly depressed, and you can get really anxious. This by itself increases the chance for substance use. And in the case of neurodivergent individuals, it requires a very specific type of interventions, because some neurodivergent people have naturally low level productions of dopamine and or serotonin, especially dopamine in the case of ADHD. Next slide, Leo. Now, in December of 2020, two dudes from King's College in England, that's Dean Connolly and Gail Gilsrick, published a meta-analysis where they took 41 quantitative studies where they were taking a look at how transgender people use drugs. And what they found is that there were up to 41 times higher rates of substance use between transgender people in comparison to cisgender people. So that's a ridiculously higher amount. Like we are a lot, like we're using drugs a lot more than cisgender people. And you know what? This actually kind of makes sense. Not just because of the fact that minority stress has an impact on our well-being, but simply because historically transgender people have been seen, and I tell you this as an Indigenous woman that comes from a tribe where Indigenous people were perceived as the spiritual leaders of the tribe. Historically, in many cultures, spiritual leaders and trans people have been the ones in charge of leading and guiding communities through the use of drugs. Through the use of drugs, we have altered our consciousness, we have access a specific type of knowledge that cannot be obtained in school, for example. And for this reason, historically speaking, we know that trans people have been the #1 drug users. Now, when it comes to mental health challenges, the reason for which using drugs can be such can lead to a problematic drug use, which can eventually lead to dopamine dysregulation and therefore mental health challenges, it's due to minority stress mostly. So minority stress theories suggest that high rates of discrimination experienced by trans people are precipitous, or they increase problematic drug use. And this risk gets worse because most substance use services do not include transgender people or are not tailored for the needs of transgender people, as my two beautiful and wonderful and brilliant colleagues, previously presenters, showed in their presentations. So the social environmental stresses play a huge role when it comes to the way that we use drugs. When there is a high level of discrimination and violence due to be transgender, due to be unemployed, due to engaging with sex work, due to gender dysphoria, or simply due to the really high visibility of gender non-conforming identities, then all of this can exacerbate and can increase the need for dissociating or for numbing the pain or for just simply trying to escape the system that is just so incredibly oppressing. And so for this reason, it's that we understand that some of the harm reduction strategies that are targeting the trans communities need to be quite specific and quite tailored. Next slide, please. Now, before I go ahead and talk a little bit about what are these strategies, I would really like to tell you about the drug and drug interactions. And I'm going to start first between recreational drugs and antiretroviral treatment. This is mostly information that you need to have in order for you to make sure that your drug use is not going to affect your antiretroviral treatment if you're living with HIV and you're taking antiretroviral treatment, or if you are on PrEP and you're taking and you're a drug user also. So when it comes to stimulants, specifically cocaine, amphetamines, methamphetamines, catenones, etc., ritonavir and covistat are by far the ones, like the two antiretroviral treatment with the highest risk of of having drug and drug interactions, which can lead to levels of stimulants which can rise really sharply, that can increase risk agitation, hypertension, hyperthermia, seizures, and even death. So documented cases are specifically showing that interactions between these two antiretroviral treatments with MDMA can really increase toxicity of MDMA, leading to serotonin syndrome, which can be fatal. So be very mindful about using these type of stimulants if you're in any of those type of antiretroviral treatment. Next slide, please. Now, when it comes to ketamine, ritonavir and cobicistat again increase ketamine levels and prolonged dissociation or sedation. Basically, if you're in ritonavir or cobicistat, ask your healthcare provider to change you if you're a drug user, like to change you into something different. We will be talking about which ones are a lot less harmful. But ritonavir and cobicistat are the ones that have the highest risk for interactions with drugs, not just stimulants as we saw, but also with ketamine, which as we know is a dissociative and a downer. When it comes to benzodiazepines, again, those two are really, really, really going to increase the prolonged sedation, confusion, risk of respiratory depression, leading to potential death. Next slide, please. When it comes to opioids, fentanyl and these two horrible ARTs that no one should be using anymore are markedly increasing fentanyl blood levels. So when it comes to methadone, however, methadone has lower interactions with, efavirenz, nevirapine, and some protease inhibitors that can lower the methadone levels. So the withdrawal symptoms will be higher. Now, with buprenorphine, the interactions are way less dangerous, but they can alter sedation levels. So the buprenorphine will not be as much as, they would not have the same effect that they will have. But buprenorphine is by far the least dangerous type of, the opioid substitute that has the least dangerous interactions with antiretroviral treatment. So definitely, strongly suggesting buprenorphine, and moving on from ritonavir and cobicistat as to be changed into other type of schemes. When it comes to psychedelics, there's very limited data, but we do know that protease inhibitors and against cobicistat may raise levels of some of the synthetic tryptamines and phenethylamines, which can increase the sense of a psychedelic trip. So it's just like way more intensified and way longer. I want to, you can pass, you can change here. But before we, next slide, Leo. Yeah, great. In here, it's just like a general harm reduction advices for you if you're using drugs and you're either on antiretroviral treatment or on PrEP. What I want to highlight in here is like the most important thing is that you need to know the antiretroviral that you're on, because especially ritonavir, cobicistat, and if your antiretroviral contains efavirenz, then there's a chance for interactions. Now, as usual, start with much lower doses, avoid redosing too quickly, stay hydrated and cool, avoid polydrug use, but then again, these are just only recommendations, and I'm not going to dive too deep into this. Next slide, Leo. And I'm sorry if I'm taking too much time, but I'm really okay. I can see Hope THR can connect with any of it. Okay, yes. So again, now when it comes to recreational drug use and interactions with gender-affirming hormonal therapy, when it comes to estrogen, the potential recreational drug interactions are mostly related to stimulants, nicotine, heavy alcohol drug use, and strong CYP3A4 inducers, such as some synthetic cannabinoids and really high dose of chronic MDMA use. So as you can see in here, mostly what it causes, what it could potentially lead to is to higher cardiovascular diseases, and when it comes to when it comes to stimulant use. So stimulants, nicotine, alcohol, interacting with estrogens, that can lead to higher cardiovascular diseases, so heart diseases. Next slide. When it comes to anti-androgens, which are often taken also by trans-feminine people, the spironolactone mostly would interact again with the stimulants such as MDMA, cocaine, like methamphetamines and cocaine, which can mostly cause dehydration, which can easily be solved by keeping electrolytes next to you when you are taking MDMA or cocaine, if you're taking also a spironolactone. This is in general like it's the solution that we have for the combination of gender affirming hormonal therapy and drug use. It's the same harm reduction strategies. It's just that you need to be a lot more aware of the symptoms that you're having. So, like, for example, if you feel dehydrated, if you feel that you're getting too warm while using spironolactone, MDMA, and or cocaine combined, then you most definitely need to take a break, take some electrolytes, cool yourself down, and then continue. I'm not going to go deeper into this one, but next slide, please, Leo. Thank you. When it comes to testosterone, so recreational drug interactions will be mostly related to high doses of cannabis, alcohol, and stimulants, as mentioned before, such as cocaine, amphetamines, and methamphetamines, including catechinones such as monkey dust or mephedrone. And again, very much related to bad cardiovascular risk. So when it comes to these interactions, if you're a transmasculine person, you're taking testosterone, and you're also on antiretroviral treatment, make sure that you're very aware of the doses and the dosing, the amount of stimulants that you're taking and how often you're taking them, because you might be risking a really increased cardiovascular risk. There's a really high risk of cardiovascular risk. Yeah. So next slide, please. Not everything about drug use is negative, and I really wanted to get to this part of the presentation because I was so tired of talking slightly negative about drug use, especially because as a drug user, which by the way I have been doing for many, many, many years, I know there's ways for me to be HIV positive, which I am, a trans woman, which I am, and a drug user, which I am, and then still manage to fucking rocket in life and be healthy and be happy. So, really good news, PrEP, which is the pre-exposure prophylactic treatment, which is a combination of two drugs, amitriptyline and tenofovir, is actually by far one of the safest drugs to use when it comes to drug and drug interactions with hormonal replacement therapy of any time, with gender-affirming hormonal therapy of any type, and drug use. In fact, taking PrEP might make you it might be really good for you because it will reduce oxidative stress. Next slide, please. Leo. All of this needs to be integrated into comprehensive sexuality education that needs to be tailored along harm reduction approaches and safer drug use education. This is one of the cornerstones of my work right now at the NGO delegation of UNAIDS, where I am the focal point for the NGO report working group. We're writing a report that is basically collecting different case studies of community-led integrated services that are bringing into one same place the provision of services that are meant and known and proved to reduce the risk of contracting HIV. So that includes comprehensive sexuality education with harm reduction approaches and safer drug use education, combined with, for example, trans-specific healthcare, mental health care support, sexual and reproductive health and rights, and so on and so forth. Next slide, please, Leo. So these are, I'm pretty sure that many of you are very familiar with this, what determines your experience while you're on drugs, but this is basically what I am advocating and what we should be advocating to be included in the harm reduction and safer drug use education approaches. So basically, what dosage, the familiarity that you have with the drug, the purity, how frequent are you using it, and the route of administration. That's all related to the drug, related to the setting. We're talking about physical surroundings, the other people present, and access to emergency help. Finally, the set, your mental and physical state, your personality traits, your preparation for the experience, and your motivation for use. Basically, the what, the how, the when, the where, the with whom, and the why. Very important question, the why, your motivation for the use. And this is the type of information that we should be getting in freaking high school. Next slide, please. Leo, great. So as I was mentioning before, if you take PrEP or or ART, especially the antiretroviral treatment from the latest generations, it's great news because it means that you are already reducing oxidative stress, which reduces inflammatory damage, enhancing dopamine signaling. So if you're a person living with HIV, if you're a transgender person who lives with HIV or who doesn't live with HIV, and if you're a drug user or one of them, being on PrEP, it's good for your brain. Do it. Now, neuroinflammation reduction, as I mentioned before, is also related to protecting dopaminogenic pathways from damage. You can take so many other different type of vitamins or other type of amino acids that will increase the production of myelin in your brain, which will protect it from overstimulation. And if you're very interested in knowing that, feel free to contact me, and I will provide you the names of these drugs. But for ethical purposes, I will not do that in this presentation. Next slide, please. Now, as I was mentioning, these integrated services for trans communities, but in general, for all key populations, are incredibly important. Why are they important? Because they address interconnected and intersectional mental health, drug use, neurodivergence, and trans-specific healthcare through harm reduction programs, approaches that are also gender transformative. These disjointed services often lead to poor outcomes. What we see, for example, with the Tangerine Clinic, and this is my number one example every single time. I just came back from Bangkok last week, literally, and it was such a pleasure to be in one space where you could literally get the clean needles, where you could get the estrogen prescribed, where you could get PrEP prescribed, where you could get everything that you needed in one space, plus counseling provided by people from your own community who had no judgment on whether it was the fact that you are trans or a drug user or anything else. And the services that we're advocating to integrate are the following, as I mentioned before. So harm reduction, mental health care, trans-specific healthcare, HIV prevention, anything, HIV within HIV continuum of care, anything within the HIV continuum of care. So HIV prevention, treatment, and testing, and linkage to care. And then sexual and reproductive health and rights combined with comprehensive sexuality education, which includes, of course, harm reduction approaches. And when I say sexual and reproductive health and rights, I also include in here fertility services and abortion services. Next slide, please. To finish my presentation, here is the list of recommendations that we are advocating from TGU and that we're strongly bringing into the NGO delegation of UNAIDS. I'm not going to read them. You can read them yourself. But mostly and most importantly, we really need to advocate for for services that are tailored to the needs of the key populations, including drug users, people that use drugs, and transgender people. And these services need to be intersectional. As mentioned in the previous presentations, we need to teach each other. We need to teach each other about trans rights and the needs of the trans communities, but also about the needs of the community of people that use drugs. Next slide, and actually this is the last one. Thank you so much, Leo. Thank you so much, everybody. And that's it from my side. Sorry, I took forever. I know I took forever.
No, that's brilliant, Amanita. It was a time well spent and amazing information sharing. And I think I think you had me at the first couple slides with the different intersections of, what it is to be trans, what it is to be a drug user, what it is to be neurodivergent, because I think sometimes even ourselves we just think of them as kind of these face value identities or experiences, but then you go into how they intersect and like the hormonal effects and the mental health and our chemistry, and it's all like how it all affects each other. And yeah, I had
And,
I had a
and
lot
when
of
you think
thoughts,
about
and
it, when you think about it, just like a quickly comment on this, Leo.
yeah,
When you are born wired, with your brain wired in a way that is just not the same way that the vast majority of people are, you are deemed to question systems, whether it's the cis norm, whether it is the hetero norm, whether it is the way that you relate to reality, the way that you relate to sex. So it just makes sense that we are such like that we have so many traits in common.
yeah, for sure. So I'd like to open it up to the other speakers and the participants to come in and engage and ask questions. One last thought I had about your presentation, Amanita, was at the end when you were saying it was so nice to be in Thailand, I think you were, or Thailand, was it? Where you could just go and get whatever you needed and it was like welcoming. I recently went back to Canada to get top surgery and it was just that, I had counseling from trans folks. I had like a doctor who knew what trans healthcare was. I got a prescription for testosterone, no problem, like everything. And it was, in a timely way. And my experience in Ireland has been, completely the opposite. So it's amazing to compare like what we can and should have to what some people have in some places. So yeah, I thought that was really important as well. So I haven't been monitoring the chat in the last little bit, but does anybody have a question that wants to come in, or Fionn or Lucille, do you want to feedback on Amanita's presentation? Anyone feel free to come in and ask questions.
Yeah,
Look at the
I
chat here.
wanted to add like two small things. Already like thanks for the two presentation. It was like super nice to have like a. I think the three of us were really linked on our presentation, and yeah, I would think that we're doing in Paris that really helps like to glue harm reduction and trans healthcare together is what we do is we call those workshops hormone harm reduction workshops, basically. And so we do this in our headquarters, but also in syringe and needle suppliers' headquarters. And so it's a group workshop with like 10 to 15 people where we discuss hormone interaction with everything, be it HIV medicine, drugs, life, mental health, medication. And then we teach people how to self-inject intramuscular or subcutaneously. And this practice really ties like harm reduction groups and trans community together because we have like the same goal for people to have the safest, well, the best information available to them, and then they can choose whatever the fuck they want to do, basically. And this is really important if you are in a situation where you need to consult a trans person regarding hormones or anything, is that in the end, they will choose what they want to do regarding their goals because every trans person has a specific goal or specific goals that will probably change during the lifetime, be it regarding hormonal treatment, be it regarding what they look like, be it regarding their name, their pronouns, I don't know. And so, yeah, it's really important to always start about what the person wants and what the person needs, and for us to exchange about the different practices that we have because we are historically groups that have been working together in most countries. For example, during the HIV crisis, a lot of drug users organizations were organizing also with trans organizations because trans population was one of the key population regarding HIV contamination and still is today. And yeah, it's very nice to see so many people there. Thanks a lot.
Thanks, Lucille. Did anyone else have a question or a comment? They can use the raising hand up function, or you can just unmute yourselves. I see some interaction in the chat, which is great between some medical professionals asking about like what could make it better for certain services for trans folks. Hopefully, some of your questions were answered during the presentations. I did have a question in terms of um, the communities of trans folks and communities of drug users that don't necessarily intersect. Like sometimes not all trans people use drugs. Not all drug users are trans. So like where those, I suppose, separations are, sometimes there can be misunderstanding or isolation. And I've experienced it myself as a trans drug user in drug user activism. So I just wanted to know from the speakers and from maybe the participants here, what, I suppose, advice or support would you give to other trans drug users who are maybe watching this webinar or who are feeling isolated or ostracized either by their queer community or by other drug users? What do you want those communities to know about, how they can get support?
can I think now though? Is I have a huge fight, inner fight in the group of multiple support managers, which we have like 3 or 4 trans women in the group, and there's a lot of stigma and
Magda, I
some
think your connection
drug
is still kind of choppy. I really want to hear what you have to say,
copy.
but it's still a bit
I'm
cutting
going to try to
out. Do you
take a
want to type it
video
in
to
the
see
chat?
if you get that. Right. Is it better without the video? Do you listen better without video?
It's a little bit better, yeah, but if you want to type it in the chat if you can, or type it to me or something.
Because I can't find your footer. Do you really don't listen? I'm on mobile data. That's the problem. Okay, I'm gonna write the chat. Okay.
Okay, while you write it in the chat, I'll let Fionn come in here.
Okay. Okay.
I was gonna say, for how do we, you said that you've experienced it, like, I don't know if you found it in the drug user community or in the trans community, but you're definitely right that these communities have a big overlap, but that doesn't mean that there's like a universal understanding. And I find that the sorts of that I think trans harm reduction, I wanted to have a drug user perspective and a drug user focus. But the reality is that the people I organize with, the people who want to organize for, self-medicating trans people in Glasgow, aren't like majority drug users. And there's like a distance from our drug user roots. And I can't really change the tide, but what I try and do is be like, hey, I'm in the room. If I'm in the room, there's someone in the room who loves drug users, and I'm gonna just I feel like that's my job. And I think the people in this like all the people in this room, they can be that people in other rooms. Like that's how I feel about it. That if I in my day job I work in mental health and substance use, and I'm the only transgender person in any of those rooms, and so I'm always trying to bring that in there. And then when I'm hanging out with a bunch of trans people who are scared of drug users because they are don't see themselves yet as a criminalized community, I'm like, well, you're actually in solidarity with them, get used to it. And trying to change their minds, trying to just remind people that we're all in solidarity with each other. We need much of the same things. In many cases, we are going to be medicalized for the rest of our lives sometimes, or have a relationship with pharmaceuticals for our lives. And we we are very close to these communities. So I just try and remind some of the, we have like young, inexperienced people who get peer support from us, and they are full of anxiety. And I love to try and remind them that it's not scary to realize that we're in community with people that you didn't think you were in community with. But welcome to the party, kid.
Thanks, yeah. Yeah, that's super important. It makes me think of one interaction I had with some cis men who were on methadone and talking about access to testosterone replacement therapy. And I was like, yeah, wouldn't it be great if we could all just get testosterone when we want it, you know? And it was a nice kind of moment of us being like, we want the same things. Amanita?
So I have two things to say about this. Number one, the communities exist. We have the European Network for People That Use Drugs, and we have Trans Europe and Central Asia. And then why on earth are we not sleeping with each other? Why are we not having more of these webinars? Why are we why are we not training each other on each other's staff on what is gender identity and what is drug use and what are the needs that we have? So this is actually something that Euro Input through Leo and through Alexi and through me, we're going to try to be doing, right? Like we want to be able to train each other's staff and communities in a much more holistic approach to what pleasure is. And I want to highlight Magda on this because I was having like an internal conversation with Magda, haha. And it's all about pleasure. At the end of the day, it's all about like, why do we have this idea that pleasure needs to be negative and bad? And it's not just about the drug use. Like, I mean, drugs are not the only thing that are going to bring pleasure into our lives. Our relationship with our bodies is going to give us pleasure. Our relationship with each other is going to give us pleasure. So deconstructing the idea that pleasure is sinful and wrong and bad, it's the first step on like from ourselves. It's definitely the first step. And then moving on to mobilize the communities that we're already part of, to understand that there are other communities that maybe we're not part of, but that have very similar needs than us. And that for this reason, we need to create those bridges and those allyships. Now, that's the first point. The second point is we need to take this to a policy level. We cannot continue drafting global HIV strategies or drafting regional EU HIV strategies without understanding the specific needs of the key populations. Why on earth are the members of the European Parliament and the people, the member states in the United Nations, not listening to the communities when it comes to the biomedical needs and the pharmacokinetics that we very specifically have? And for that reason, also researchers, both biomedical researchers, but medical researchers that are doing clinical trials need to start including trans people and people that use drugs in their specific research, because there's no disaggregated data. And the reality is that the very little data that is available out there is already pointing to the direction of like, yes, girl, actually, we have different biologies, we have different brains, we have different interactions. And for that reason, if you don't put them into your research, then your data, your outcomes, your results are not going to be of any use for the response that we need. Next to Luciole.
Thank you, Amanita. Yeah, and Magda just wrote her question to me, and it was about what we're talking about now. How do we address discrimination amongst drug users towards trans people? How to make them more understanding when they're suffering from the same kind of stigma, and yeah, just making an effort to be aware how each community is kind of under similar oppression. So thank you, Magda, for typing that in. Lucille, you want to come in there?
Yeah, I, I'll give an example afterwards, but I think a main strategy that we're using with our transit talks is I think we need also to recenter the question around prohibition and how prohibition is fucking everybody's life. And for trans people, usually, yeah, there is the thing that, yeah, we're only using your hormones, we're not using drugs, we're not like, but it's kind of the same struggle in the end. It's a product that we use for our pleasure, our life, and that is under medical control that you cannot access and use by yourself. Otherwise, you're going to be criminalized. And right now, hormones brewer, for example, in Europe are not in prison, but in 10 years, with the rise of fascism, it could happen, and it can happen quickly. And it's the same for drug user. And for example, in France, and there's somebody with I'm organizing with in France, which is Karim, and we are a trans group, but we are working with other like a mutual aid collective for drug users. And I don't know, we met for the Support Don't Punish Day, and it was super nice because I mean, yes, we came as a group of like trans people, kind of a degenerate, half-naked trans people. But then we bonded with other people because the thing is, we were here regarding like drug issues, and we got each other quickly. Like we were facing the same problems, we were having the same discussion, and also, yeah, let's talk about medical violence. How the medical system is like so awful for all of us. And I think people get, even though people can have like transphobic tropes or transphobic ID, they get what pain is and they get what discrimination is. And usually it's the first thing that they talk to us about is that, okay, it must be fucking hard to go see a doctor and ask about like hormones and shit. And I think it's nice talking point to start about like what do we have in similar and how different systems are fucking our lives up. And it's not our fault that we are in this shitty universe, but we're gonna fight together basically. And yeah, I think really making political alliance is like the key point, and it's very nice that TGU and European U are doing things together. For example, like for me, it feels super nice. So yeah, and I think it's way easier than people think it is. Actually, also, I think people have fears, and it's normal because we are marginalized population, and we have been through a lot. But it's also about what I mean, people who do not have much power won't do you so much harm, basically. So it's also at some point you need to take risk when you meet new people. That I think the risks are worth taking, basically.
For sure. Thanks, Lucille. That was great. Um, yeah, I mean, it's this webinar is so great. Uh, for me personally, like I'm so glad that everyone could be here, and just the information that we're sharing, and like the solidarity that we're creating just from, an hour and a half online. I think we can do so much more in person, and I'm really looking forward to continuing working with TGU and other folks here. Amanita.
Leo, could you maybe repeat Magda's question? Because I'm not entirely sure if we addressed what Magda wanted to ask. Was that already addressed?
Yeah, so Magda's
Can you
question
listen to me
was,
better?
oh, you hear Magda? Can we hear you?
Yes, I can hear you better. Can you listen to me better? Because I found a router.
Can hear you a little bit better.
Not
Yeah.
really. Yeah. So my questions are in the support group where we have trans women. There's still, even though the group is on the way of 4 years of existence, actually, people that use drugs, the females in our group, they are very stigmatizing towards the trans. As more as I try to make them understand what is gender identity, what is the struggles that they have within themselves, because a lot of people here don't have the notion of the rates of suicide on the trans community, because they feel misrepresented, because the gay community doesn't represent the trans community, and the doctors in the beginning address them as they are with some kind of confusion when they try to move towards hormone treatment, and it's not. I believe it's not the right way to address a person that goes to an appointment on that matter. It makes the person from the beginning thinks that there's something wrong with them, and that makes them become, most of them, they use sex work, they use drugs to cope with trauma. They come from families where their own mothers most of the times blame them for being boys that became females, and they caused some kind of disruption in the family status quo. There's still, how do I say, like the gay community in Portugal, it's well accepted, well exposed. The trans community is still a niche that is obscure. It's linked to chemsex. It's linked to sex work, and they are seen as outsiders, as weird beings, which is, I think, super stigmatizing and super hurtful. And I have no fear to say sometimes I don't know how to do better to make them understand that actually they suffer from the same kind of stigma from the society. They treat drug users like garbage, and they treat trans like weird human beings that have some kind of problem. And that makes people in the level, in an emotional and spiritual level, become hurt from beginning. And those statements that society reinforces on the trans, they become scars, and those scars are very hard to take. I don't like to see, for example, when I have one that is going through hormonal treatment, and she is actually emotionally very unbalanced, and they are not supportive with that. I have to actually address her and be with her after the meetings because she's in an immense emotional pain, and I don't feel that she has support from a doctor, or I don't know what's missing. I don't know what's missing there. I actually don't know.
Amanita, do you want to respond to Magda?
Yes. So, I mean, honestly, I know that this sounds like just the repetition of the repetition, but two things. First and foremost, we just really need higher representation of both communities in as many spaces as possible. With that, I mean, and I'm gonna like throw some shading here a little bit, not shade, but more like wink, wink. It cannot be that Leo is the only trans person working at your input, like as a staff. There has to be more trans and gender non-conforming people working at Euro input. And I am telling you this factually, I'm not the only drug user in TGU, which is the only reason why we have been able to like start like pushing a lot more for this like relationship that basically started last year in Barso. But last year, like, I mean, it's 2025. How is it possible that it didn't happen earlier? That's one thing. So yes, we need more representation, but we also need more representation of trans people in harm reduction services. Like as I was mentioning before, it's very different when a trans woman comes and sit in front of a cisgender heterosexual man who's a drug user and to talk about her, let's just say, problematic drug use with any drug. I don't know. It doesn't matter. But it's quite different when she's sitting with you, Magda, at GAT, and like it makes a huge difference. Now when it comes to those conversations that need to happen, I feel like we need to distance ourselves a little bit from the way that we do things normally. I say, let's sit and let's do some ketamine together, or take some mushrooms together, some acid together. Let's enhance empathy between each other, and let's have conversations, because that's how we should be doing things to begin with. That's how the indigenous communities were doing it to begin with. That's through Amanita, the conception of Amanita muscaria, not me, the mushroom. It was what it meant. It aimed to reduce our egos, increase empathy between the members of the tribe, and just have conversations that were uncomfortable to have, but that were necessary for us to be able to build a stronger community. Let's sit together, let's do drugs, and let's talk. How about that?
That's great. I'm all in favor of that. Sorry, Magda, go ahead.
It's working. Yeah, I do agree what you said, Amanda, because I actually have noticed when I take cannabis to a meeting, the conversations flow in a totally different level with people. I don't know what happens, but actually cannabis works in its wonders, and something happens. And actually, what you were referring, Amanda, I wish we could do psychedelics together, but it's not easy to get psychedelics to do with them. But we already did the cannabis thing. And this month, the tool that we found was we have a person that comes to be the dynamizer of the activities, which is Tita Maravilla. And Tita Maravilla is a trans that came and caused an impact that I actually saw on the last meeting, but saying, I came here because of you, Tita. So when we bring um, a trans, an empowered trans, to work with a group that shows them uh, without no fear or without no layers who she is, her inner child, because she's working on our inner childs, something magical is happening. And Tita Maravilla is a woman that already did the whole process, and the first session they were not aware that she was a trans. And when she told them, actually, the reaction was good, and this was super rewarding. To listen on the second meeting, they were saying, we came for you, Tita. So things can happen, but we actually need more trans people engaged on these support groups in order
Magda, your connection is kind of going again, but I think what you're saying
again,
is really important, and I want to capture it. Maybe the video off is better, but just to say, Magda,
I
like
want to
you're talking about
engage
your support for
group now and
say again, sorry?
dynamize the support group this month of August as a person that came to do dynamization of activities with the group, which is Tita Maravilla. You can see her Instagram, and she is a super empowered trans woman that does performances that actually show how ridiculous the stigma is, because she provokes it in the streets and people get aware that they have reactions that are nonsense. And on the first session, they were not aware that she was a trans Tita, and it was very rewarding to see on the second meeting, girls were saying, "We are here because of you, Tita." So I think having more trans people engaging in these support groups in order for people that use drugs don't stigmatize the trans community, because it is
Yeah.
support groups.
And Magda, I think your
The-
involvement in Manus and what I've
yeah,
seen when I've visited Lisbon and visited you and the members of Manus is that you have that support intrinsically. You know, it's open to trans women, it's inclusive and inviting, and it's a welcoming space. Like anytime I'm there, it seems to be like a positive, welcoming space, you know? And I think that's you're a part of that, you know? You were a part
yeah,
of making that.
yeah. I think involving this dynamizer that is a trans woman, it's going to be a key element to change a lot of the attitude of looking to the trans women or our group that are not one or two. They are about
Yeah.
four at least. Um, and I have hopes that actually Tita will actually make them look at the trans in a different way. And the only thing that I don't know what to do, and I already told, is how to do
Yeah.
trans support each other more
Yeah.
among
Well,
them.
I hope, like Amanita was saying, linking in more with TGU and Euro Input, I hope we can kind of, as a regional network, push this kind of connection and support and growth within the drug user groups that we already connect with, you know? Um, and drug user groups that are already made up of trans folks like Manus. I think, you know, um, involving you all in something like that would be really interesting, I think. Um, we just are a little bit over time. I want Lucille to come in here. Lucille.
Yeah, just quickly, I think one of the strategies that can be used when you have I know, a few trans people in a group of drug users, is also having some kind of in supplement a non-mixed discussion, basically. That way you can have like a space for, I don't know, only trans people or women and trans people, basically, because strengths come in number also. And when you arrive at a meeting for drug users and you are the only trans person or you are only two trans person, it's kind of hard. But when you arrive and you're six or seven, I don't know, the flow changes, like the tide changes, something is happening. And also it's important to have those non-mixed spaces to create solidarity also between people. Because, for example, a thing that I'm organizing every week, every 2 weeks, is a space for trans women. And we are like 80, 90 per session. And at the start, people were not in solidarity with each other. Like girls were going at each other's throats over clients, over who is the most beautiful, whatever. And it just by repetition of the workshops and of the discussion, the girls were starting to be friendly with each other because also and then they were backing each other up when they were going to other spaces with these people, for example. And so, yeah, it's important to create multi-level of support, basically, I think, for marginalized group.
Yeah, for sure, Lucille. Thank you for that important note. And I think it goes back to what someone, maybe yourself, was saying about GPs and basic knowledge. Like, we're not expecting people to know everything right away. And at the same time, we're not expecting that tomorrow we will have like a European, mutual aid transpositive network. We build these things over time with each other, and there's bumps along the way, and you know what I mean. People develop relationships um and figure out how to work together, but it's worth it, right, to try to do that. I'm gonna close us off there. I just want to have maybe one last word from each of the speakers in closing. Thank you all, everybody, for coming. We are going to share the slides. Thank you for coming. Yeah, Amanita.
I need to go like in right now, but before I go, I just want to leave one last thing. The trans communities and for those that are trans people here, we know that we organize, or that we have very different ways of relating to each other. We have families that are usually not our blood relatives, and we have quite often mothers and fathers and parents that are other trans people that are basically just guiding us to how to survive. I personally have 7 beautiful children that I live with, chosen family. Yeah, 7 beautiful people, trans people that I live with. And I have made sure, because I started living with them since they were 19, like really early, since 4 years ago, 4 years now. And from the very beginning, I made sure that they had all the necessary information to make the conscious choices about drug use, sex work, transness, everything. And we had strategies to make sure that they have the support that they need to engage with whatever it is that gives them pleasure and makes them happy, but also making sure that it doesn't take away their well-being. I'm happy to say that 4 years later, many of them have chosen to not use drugs, but also many of them have chosen to use drugs, and none of them is having any type of like really problematic drug use at all. And it's proof that when you from an early age you start educating people and sharing knowledge about different ways of doing things, people flourish because they're allowed to be themselves. And that's the last message that I want to leave you. And now I have to run because I have a birthday party to go to and I'm super late. Kisses, everybody. Thank you so much
Thank
for
you,
everything.
Amanita.
Bye.
Thank you, Amanita. Fiona, Lucille, do you want to come in quickly before we end off there? Just to say.
I'll come in. I'll be very quick. I thought that was great from Amanita. I thought it was wonderful, and what an amazing presentation she had as well. I want to think about the thing that Lucille said right at the start of her presentation, which was that the principles of harm reduction are the kind of principles required to be inclusive of everyone. I think that I'm going to steal that. I'm going to be using that everywhere. I think it's like really powerful. And what I'm thinking about, like I'm in the UK, the situation in the UK is getting worse and worse all the time. And Leo, like you said, in Ireland, it's not much better. Like it's politically like a bit better, but like in like actual like on the ground, do you have any access to hormones? No. Like, and so we're operating across two spaces where there's a lot of like kind of energy in the community to make a difference and make something change. So I'm surrounded by a bunch of people who've never done this before, right? And what Amanita was saying about fostering community and chosen family and taking care of each other, I think that it's important if we think like, oh, I want to be involved, I want to make a difference, I want this has to change. We have to foster ourselves and take care of each other and like get the training, learn from each other, and join a union. You know, unions will teach you stuff. There's a lot we can learn from unions about how we should operate, I think. And that's just one of my thoughts on it. And I think there's a lot to do, and we have to be well enough to do it together. So we got to take care of each other. So that's my final word.
Thank you, Fionn. Lucille, any final words from you?
Yeah, it was super nice, and just I think that was important. I think is remember that you can only explain any drug use by the benefits of why people are doing it. Like people are taking drugs because they need something, they want something, they are looking for something, and it's really important to highlight the positive and the why people do it, and not fall into some kind of pathologization and only talking about like a problematic drug use. And thanks a lot for the invitation. It was so nice.
Thank you, Lucille and Fionn, and to Amanita. Thank you all for being here. And yeah, I think that what to Fionn made me think of this is that our existence is resistance, right? It's easy, like we foster each other, and the resistance is there. It comes as we exist and foster relationships with each other. So thank you very much all for coming. I'm going to end this now. For folks asking about the recording, we're going to send the recording and the slides to all the people who registered. And if you want to get in contact, the email, Instagram is there. And thank you so much. And